All right, let's jump right in. If you're doing any time in cardiology or on a CT surgery service, you're absolutely going to see patients with LVADs. And one of the single biggest headaches we face with these amazing life-saving devices is infection. So think of this as your quick and dirty guide to tackling LVAD infections.
So, picture this. You walk into your patient's room. They've got an LVAD, they're spiking a fever, and that driveline site just looks angry, red. It's such a classic scenario. What's going through your head? What's your immediate next step? We're going to walk through exactly how to think about this.
So here's our game plan. First, we'll cover the basics, what the device is and why it gets infected. Then, the really crucial part, figuring out what kind of infection you're dealing with. After that, we'll get into the workup, the treatment plans for each type, and then we'll wrap up with outcomes and, most importantly, how to prevent this whole mess from happening in the first place. Okay, part 1, setting the stage. Look, before you can treat the infection, you've got to understand the hardware and exactly why it's so vulnerable. So, what is an LVAD? At its heart, it's a mechanical pump doing the work for a failing ventricle. Simple enough. But the component that should make you nervous, the part that's our focus today, is the driveline. It is, without a doubt, the device's Achilles heel. It's literally a cable that runs from the pump inside the body, tunnels through the abdominal wall, and connects to a power source on the outside. It's a direct bridge from the outside world into a patient's sterile body cavity.
And just how big of a deal is this? Well, check this out. A major analysis found that over 3 years, almost 26% of patients got an LVAD-specific infection. Let that sink in. That is more than 1 out of every 4 patients. So this isn't some rare zebra diagnosis. It's a common, incredibly serious problem that you have to be ready for. Which brings us right to our second section, know your enemy. And this is so important. Not all LVAD infections are created equal. And I'm telling you, correctly identifying the type of infection is the single most important thing you'll do. Why? Because it dictates everything that comes next.
First up, we have the driveline infection. The name says it all, right? It's an infection that's stuck right there, localized to the cable and the skin and tissue, right where it pops out. This is, hands down, the most common type we see.
Next, you can have an extravascular pump infection. So think of this as an abscess in the surgical pocket where the pump itself is sitting. The key distinction here is that the infection is on the outside of the pump hardware, the parts that are not touching blood. And then there's the one we all dread, the endovascular pump infection. This is when the bugs get onto any surface that's in contact with blood. We're talking the inflow cannula, the guts of the pump, the outflow graft. This is basically a device-related endocarditis, and it's a whole different ballgame with huge systemic consequences. All right, part 3, the clinical investigation. So you're suspicious? How do you prove it? And more importantly, how do you figure out which of those 3 types you're actually dealing with? Time to put on your detective hat. These are your big clues. The most obvious thing is going to be redness or, pus draining from the driveline site, but you have to ask about and feel for pain along that driveline tract or right over the pump pocket. And of course, look for fever, those vague systemic symptoms like feeling wiped out, not wanting to eat, and sometimes even a sudden worsening of their heart failure can be a sign. This here is your step-by-step game plan. It always starts at the bedside. Good history, good physical exam. Then you get your cultures. You need at least 2 sets of blood cultures from 2 different spots. And if you see any drainage, you better believe you're swabbing that for culture too. Run your basic labs. And then you've got to move on to imaging, usually a CT scanner and echocardiogram, to see what's brewing under the surface. And here are the usual suspects we're up against. About half the time, it's a gram-positive bug like Staph aureus, and that tends to pop up early, within the first 90 days, which makes you think it might have been seeded during surgery. After that 90-day mark, though, we start seeing a lot more gram-negatives, especially Pseudomonas. This timeline can be a super helpful clinical clue. And now for the main event. Section 4, making the right call. You've done the workup. You might know the bug. You've classified the infection. So what are you actually going to do about it? Okay, so for driveline infections, our most common type, it's really a tale of 2 pathways. If it's uncomplicated, we're talking just some local redness and drainage, you can often manage these folks as an outpatient with a few weeks of oral antibiotics. But the second it gets complicated, if there's an abscess, dead tissue, or signs of sepsis, that's a totally different story. That patient is getting admitted for weeks of IV antibiotics, and they'll probably need to go to the OR for a surgical debridement. Getting this distinction right is absolutely critical. Now, if that infection is sitting in the pump pocket, the extravascular kind, the whole game changes. This is an automatic admission to the hospital, no question. They're looking at a long course of IV antibiotics, at least 6 to 8 weeks, and surgery isn't optional here. It's required to really clean things out. And even after all that, they often end up on long-term suppressive antibiotics, maybe for life.
And for those endovascular infections, the management is just as intense. Admission, a long haul of IV antibiotics, and very often long-term suppression afterwards. But here, if the infection just won't clear, you have to start having the really big conversations about major surgery, like a full device exchange, or even pushing for an urgent heart transplant if they're a candidate. The stakes are incredibly high.
So finally, let's pull back and take the long view. We've talked about treatment, but what are the real consequences of these infections? And, what can we do to stop them from ever starting?
This chart, wow, it really says it all. Just look at the massive difference in 1-year survival. If a patient gets a driveline infection, they have about an 87% chance of being alive a year later. Not bad. But if that infection involves the pump, either on the outside or the inside, that survival rate just plummets, down to between 58 and 66%. This right here is why figuring out the type of infection is so unbelievably important.
And to put an even sharper point on it, getting any kind of VAD-specific infection nearly triples a patient's risk of death. It is one of the biggest factors that will determine whether they have a good long-term outcome or not.
So how do we prevent this catastrophe? Well, it really comes down to 3 big things. Number 1, using the right antibiotic prophylaxis when the LVAD goes in. Number 2, obsession with sterile technique in the OR. And number 3, and this is where every single person on the team, including you, has a huge role, meticulous driveline site care. We're talking perfect aseptic dressing changes and making sure that driveline isn't wiggling around.
So I'm going to leave you with this to think about. Knowing what you know now, knowing how deadly these infections can be, what is the one single thing you can do on your very next shift to help prevent one? Maybe it's just watching a dressing change to make sure it's done right, or checking to make sure a driveline is properly secured. Because at the end of the day, prevention really does start with us at the bedside.